We made these guidelines because of the results of the Capitello 291 trial, which looked at the combination of capivasertib and fulvestrant in patients whose disease had progressed on prior aromatase inhibitor, and found that there was benefit of the combination of these two medications. And the guidelines are helpful because there were some differences between some of the patients included in the trial and most of the patients who were seeing in the first line setting. So about half of the patients in the trial had received a CDK4/6 inhibitor in combination with their aromatase inhibitor, and half had not. So it was helpful to look at a little bit more detail to make sure that it made sense to be giving these medications in combination post CDK4/6 inhibitor, which is the case for most of our patients in their first line. And other things the guidelines addressed were some of our patients recur on or shortly after completing adjuvant aromatase inhibitor, and for that reason are given first-line fulvestrant in combination with a CDK4/6 inhibitor. That population was not specifically addressed in this trial or studied in this trial, but the guidelines, after discussion in the group, said that it was okay to try this combination of medicines in patients who had progressed previously on fulvestrant in combination with the CDK4/6 inhibitor. I think the guidelines were also helpful because what to choose in the post CDK4/6 inhibitor setting as second-line endocrine therapy is a little bit unclear. There's not a definitive, this is the best treatment for somebody who has progressed on first-line CDK4/6 inhibitor treatment. For patients who have a PIK3CA mutation, we already have the medication alpelisib, and capivasertib includes patients who have a PIK3CA mutation as well as patients with AKT mutation or PTEN alteration. And so there was a question about, should we be offering capivasertib preferentially to patients who have this alteration in the same pathway over alpelisib or not. And we made that decision mostly using information about the difference in side effect profiles between alpelisib and capivasertib. Alpelisib tends to be a medicine with a lot of side effects, and while capivasertib also has many side effects, especially hyperglycemia rates were lower in the Capitello trial than were seen in the trials with alpelisib. And then I think also the guideline conversation was helpful because patients who have both a PIK3CA mutation or AKT or PTEN alteration, as well as an ESR1 mutation, have the choice between a medicine that targets AKT or PIK3CA, as well as a medicine that targets ESR1. So having a conversation about which of these patients we would preferentially give capivasertib to versus elacestrant, which targets that ESR1 mutation. And the conversation that we had showed that we came to the consensus that for patients who had been on their first-line CDK4/6 inhibitor for longer, so for at least 12 months, we had a slight preference for giving elacestrant over capivasertib in combination with fulvestrant if they had both an ESR1 mutation and a PIK3CA mutation. But for patients who had been on a CDK4/6 inhibitor for a shorter amount of time, that we would prefer capivasertib plus fulvestrant. Update that we issued came with some new information that the FDA issued regarding hyperglycemia monitoring with capivasertib. So with the initial approval, the rates of impaired fasting glucose were reported to be about 18%, but with additional monitoring, the rates of impaired fasting glucose are up to 37% of patients receiving capivasertib. This is still less than with alpelisib, but a meaningful increase. And there were also some increases in the rates of more severe adverse effects, so people requiring starting insulin or even being hospitalized because of their high blood sugars. And because of that, we just changed our recommendations for monitoring based on the FDA's recommendations, monitoring of fasting blood glucoses. So we recommended that patients have blood sugars checked in the window of time. So capivasertib is given 4 days on, 3 days off, in that window of time where they're off of capivasertib or toward the end of the capivasertib in the first week, the second week, and then every other week for a little while, and then also monthly going forward. And then for patients who you have concerns about being at higher risk for hyperglycemia, we updated the guidelines to recommend that they actually go home with the ability to monitor their fasting blood sugars at home with a glucometer and lancets and test strips. In combination with fulvestrant are rash, mouth sores or stomatitis, and diarrhea. And so we have recommendations in the guidelines about prophylactic medications to recommend if patients are experiencing this, because the risk to benefit of starting an antihistamine medicine, which has been shown to reduce rash with alpelisib, is pretty low. It's, not so risky to start an antihistamine medicine and can provide a lot of benefit if someone doesn't ever develop a rash. We actually recommend that all patients who are starting capivasertib plus fulvestrant also start some sort of antihistamine like cetirizine to help reduce the development of rash. We also recommend that everybody go home with a prescription for loperamide to take if they develop diarrhea on this medicine. And then we counsel our patients extensively about the risk of stomatitis, at home things they can do with baking soda or saltwater mouth rinses, and then also having a very low threshold to start a dexamethasone mouthwash to swish and spit, which was shown to be very helpful at reducing significant mouth sores with everolimus and has also been very helpful for patients. And then in terms of safety with the blood sugars, we talked about the option of sending patients home with a glucometer, especially patients who you think might be at higher risks, like patients who have an impaired fasting glucose at baseline, patients who are receiving steroids for some other reason during a period of illness, patients with obesity or other metabolic syndrome diseases.